Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McCrae.
Tracy, doctors at the Mayo Clinic performed the first organ transplant way back in 1963. 1963. Now, let's see. I was still in high school. You weren't even born.
Not quite,
I mean,
no.
It was a while ago, and it was done at St. Mary's Hospital right here in Rochester, Minnesota. Now, since that first transplant, which was a kidney, Mayo Clinic has actually grown into the largest integrated transplant provider in the United States. Amazing story.
Wow. Across Mayo Clinic's 3 campuses in Arizona, Florida, and Minnesota, more than 150 surgeons and medical doctors plus hundreds of allied staff are being trained every day in transplant specialties, including heart, liver, kidney, pancreas, lung, hand, face, as well as blood and bone marrow transplants.
So the younger generation is coming along. We got to have somebody to be able to do this when Dr. Edwards and I are gone.
That's right.
There's
you're going to cough. You're not going to cough. Okay, we're good.
Which one? Where are we?
That's all right. There's a lot going on.
There's a lot going on in the world of transplant, and who better to talk about it than the director of the Mayo Clinic Transplant Center, Dr. Brooks Edwards. Dr. Edwards, great to have you back.
Good
nice to see you.
Thank you.
So you are head of a pretty big operation, it sounds like.
Well, we have here in Rochester a transplant program that does roughly 1,000 transplants a year. That's
all different organs.
All different organs and blood and marrow transplant.
And how many physicians involved, both physicians and surgeons, medical doctors and surgeons?
Well, we have roughly about 15 transplant surgeons and close to 60 transplant physicians.
Pretty amazing. And what are the most common transplants that you're doing here at Mayo today?
So here, the solid organ transplants, the kidney transplant program is our largest program, and we do around 220 to 240 kidney transplants a year. We'll do about 125 liver transplants, and then we do heart, lung, pancreas, and face and hand transplants as well.
Is the kidney transplant the largest of those because of the need of people who need kidney transplants, or because you can have a living donor kidney transplant?
Well, it's a mix. Certainly, living donor kidney transplant does provide a benefit for patients in need of kidney transplant, but the number of patients waiting on the transplant list, the largest group are the kidney transplant patients. Overall, there are over 120,000 patients waiting right now in the U.S. for organ transplant, and somewhere around 60,000 of those are kidney transplant.
How can you determine if someone is a good candidate for a transplant? Because they're sick, obviously sick enough that they need to have a transplant, and I would imagine that makes it harder for them to survive a surgery like that.
Right. Well, the patients do need a good evaluation, and we look over the rest of their systems to say, are they in good shape for a transplant? And very often, if the kidney is the only organ that's failing, then they'll do very well with kidney transplant. And in fact, most patients with kidney transplant are out of the hospital on day 3 or day 4.
Pretty amazing. So tell us why there are so many kidney transplants. Why is that the most common one? Is it because the kidney is a vulnerable organ to disease? And the other interesting thing is you got 2 of them.
Right. Well, the kidney certainly is. It's a critically important organ. And as the kidney begins to fail, patients experience a number of symptoms. They lose their appetite, they're weak, their bone marrow also kind of falls behind things. And in our society, unfortunately, a number of things that cause kidney failure are prevalent. So hypertension, high blood pressure is a leading cause of kidney failure. Diabetes, especially as it's related to obesity, is a very common cause of kidney failure as well. In our society, diabetes is on the increase, especially associated with the obesity crisis. As patients gain weight, they become insensitive to insulin, they develop diabetes, and one of the consequences can be kidney failure.
Would you say that's the most common reason to do a kidney transplant today is because of complications related to diabetes?
It's one of the more common reasons. There are a number of disorders. There are genetic disorders and environmental disorders that can result in kidney failure. And so diabetes is certainly a common cause, but not the only cause we see.
The liver is an interesting one because it's relatively new on the spectrum, right? I mean, 30 years ago we weren't doing liver transplants.
Right,
Why
really
now?
the infancy.
Why now?
Well, we were in the infancy of liver transplant 30 years ago, but there are a number of diseases that are increasing prevalence that are resulting in liver failure. And so the things we see, again, being overweight, obese, obese patients can develop fatty liver, and fatty liver can progress into a cirrhotic liver and need transplant. Hepatitis C is now a disease that when we identify, we can treat medically, but for patients who've had long-term hepatitis C long before treatment was available, those patients gradually develop progressive liver failure, and that is also a common cause of needing a liver transplant. And unfortunately, alcohol abuse continues to be a problem in our society, and those patients can develop liver disease as well.
The situation of obesity and the effect that it ultimately has then on someone needing an organ transplant, is that adding, because that's becoming the problem is increasing, is that adding people more and more to the waiting list?
So the waiting list for each organ continues to grow. It does vary. The liver waiting list has not grown dramatically over the last couple of years. Kidney transplant waiting list does continue to grow. The question of obesity and liver transplant, being obese, especially in patients who are very overweight. So if we think of a normal BMI as somebody having a body mass index around 25, many of these patients have a BMI of 40 or 45 and are oftentimes several hundred pounds overweight. You can imagine that's a very difficult operation. And our surgeons now have, in a clinical study, combined a liver transplant with a bariatric surgery. So at the time of liver transplant, they do a type of gastric bypass operation. And so far, that's been very successful for these highly overweight patients.
Tell us about lung transplants. How many do you do every year? How successful are they? And what are the indications?
So across the Mayo spectrum, we do lung transplants in Arizona, Florida, and Rochester. And collectively, we'll do about 60 to 70 lung transplants a year. Lung transplant is done for a number of diseases that affect the lung. COPD is a common cause. Oftentimes that's related to smoking.
That's bronchitis or emphysema.
Bronchitis or emphysema. Other patients develop fibrosis in their lung, fibrotic lung disease. Scarring of the lung, and that can require lung transplant. And then vascular problems can also occur in the lung. So patients have high blood pressure in the lung, pulmonary hypertension, and that may ultimately need a lung transplant. So it's a spectrum of diseases that bring patients to lung transplant.
All right. Well, it's good to have you with us. We're talking with the director of the Mayo Clinic Transplant Center, Dr. Brooks Edwards. Time for a short break. When we come back, we'll be talking about the importance of organ donation, clinical trials, and the ongoing transplant research at the Mayo Clinic. Plus,
and myth or matter of fact, every 10 minutes, someone is added to the National Transplant waiting list. We'll find out.
welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McCray.
Our guest is the director of the Transplant Center at the Mayo Clinic, Dr. Brooks Edwards. We'll talk about research at Mayo, clinical trials, and the importance of organ donation. But first,
myth or matter of fact, every 10 minutes, someone is added to the National Transplant waiting list. Is that a myth or is that a fact?
That is a fact.
So 2 people added to the transplant list before the end of your interview. Wow. And there's 120,000 people right now waiting for an organ, I heard you say?
That's right. So I like to have people think of that in human terms. If you took the Rose Bowl Stadium in Pasadena and filled it, 100,000 people, you'd have 18,000 people waiting outside to get in, and they'd all need organ transplant.
Gosh, when we took the break, we were talking about lung transplants, and that just made me think, the usual lung transplant, is it a double lung transplant or is it usually just a single?
It's about 50-50. In some cases, patients can do very well with a single lung transplant. For some diseases, such as cystic fibrosis, where there's a lot of infection in the lung, we would favor double lung transplant. Pulmonary hypertension, similarly.
So you've been the director of the Transplant Center now for, I think it's 8 years. What's happened over that period of time that's most impressed you?
Well,
what have you done that's really
Well,
good?
it has to be something that we kind of glossed over at the very beginning of this interview when we mentioned hand and face. So that has to be part of it.
Certainly, we're doing additional transplants now. So we do hand and face transplants. That's a very small niche practice. Many patients don't need transplant for facial issues or even a unilateral amputation, but there are some patients who will get tremendous benefit from that. The other thing we've done is we've worked hard to expand the availability of donors for patients waiting for transplant. So, for example, in our kidney transplant program, we now have paired donation and donor chains. So if you have a donor but is not compatible with you, your donor can give to another patient and their donor can give to you. And that has accounted for about 30% of our living donor transplants in the last year.
30%?
30%.
Wow.
So that's been very beneficial for patients, and they ultimately get a better match by pairing their donors. And then in the liver transplant arena, we do living liver transplant. So if a patient is in serious need of a liver transplant, is unlikely to do well waiting for a deceased donor, they may have a living donor who would take, we would take part of their liver, about half of the liver, and use it for the recipient. The interesting thing about that is the donor, their liver grows back how fast?
6 months.
6 weeks.
No, really?
Very quickly. About 90% of the liver's regenerated in about 6 weeks.
It's incredible, isn't it? It's the
incredible.
only organ that can do that.
It's our starfish.
But we have learned from interviews with Dr. Rosen that still when it would come to a liver transplant, that a deceased donor liver might be better than a living donor.
Yeah, so there are situations where a deceased donor organ may be better. There are also situations where patients may not do well waiting for a deceased donor, and if they have a living donor, it may be a preferable option.
What have you learned about when it comes to doing something as amazing as a face transplant? What have you learned about how to perform a transplant from a process such as that? I mean, it's not necessarily a new horizon, but it almost is.
Well, I think the important thing about face transplant, or truly any transplant procedure, first of all, having an integrated team working together. So here at Mayo Clinic, physicians, surgeons, nurses, specialists in immunology, and all kinds of different medical areas, infectious disease, psychiatry, and so on, all come together and bring their care to that individual patient. That integrated team is irreplaceable in terms of outcomes for transplant. The other thing we've learned is that selecting the right patients up front is critically important, and patients have to understand the issues of transplant, the downsides of transplant, the expectations that we will place on them as recipients. And if they go into it with a good understanding, they're likely to have a good outcome.
What are some of those expectations?
Well, patients after transplant will require medication lifelong. They'll be on a regimented medical routine, taking medications. They'll need follow-up, regular follow-up in a transplant center, and so on. Most patients after transplant have a quick recovery. They can get back to work, they can get back to travel, they can get back to all kinds of leisure activities and family activities. but there are boundaries that they have to adhere to as well.
All right, a couple other topics we want to cover before we finish up, and clinical trials and research. So tell us about clinical trials and how are you using them and how are they helping you in transplant surgery?
Well, if you think about the advances that have been made in transplantation, the development of new drugs to help target the immune suppression, new drugs to deal with infectious risks or complications that we may see after transplant, these all come through clinical trials. We in the heart transplant program have, I would say, pioneered the trial of a drug called sirolimus for immunosuppression that it turns out is dramatically better in preventing some of the long-term complications we would see at 5, 10, 15, and 20 years out from heart transplants.
So by immunosuppression, you mean anti-rejection drugs?
Anti-rejection drugs, right.
Okay.
And so having these clinical trials available and bringing the newest and best therapy available for patients has had dramatic impact on the long-term outcome for patients.
All right, what about research? Now, I know a decade, 10 or 15 years ago, I remember there was going to be a big emphasis on trying to figure out how to use pig organs, and so we wouldn't be so dependent on human donors. Where does that program stand?
Well, there's still interest in using animal organs. It's called xenotransplant. There's also increased opportunity now as we understand the human genome to try and create some organs that express human genes in an animal. And perhaps if we do that right, we could create an organ in a pig that would not be rejected by the recipient because it would identify it as self. So that work is ongoing. We have people in the laboratory doing those sorts of studies to try and better identify what genes are important in the rejection phenomenon and how those could be inserted into different hosts.
What's the next frontier in transplant surgery?
Well, I think in many ways it's a iterative process. So there are small incremental improvements that may occur. Ultimately, I think we do have opportunities for biologic solutions like cell-based therapy. So if we talked about how the liver can regenerate, if we could take and rid your liver of the bad cells and repopulate it with a cellular transplant, that may be a huge game changer. We're not there yet, but there's a lot of work ongoing, and we'll see how it goes.
And at the last opportunity for you to give a plug for why people should consider becoming a transplant, a donor themselves.
Well, it truly is the gift of life. Organ donation saves lives, and we see it in our practice every day. Patients who may be really very close to end stage of their life, and all of a sudden a donor organ becomes available. Some family has made that decision to not bury their dead one's organs, but to use those for carrying on the gift of life. Families find that an extraordinarily satisfying experience, and I think it often helps them in a difficult time, and clearly dramatic improvement for patients.
Dr. Brooks Edwards, congratulations on a wonderful and successful tenure as director of the Mayo Clinic Transplant Center, and thanks so much for being with us.
A pleasure.